The urinary system is relatively simple from a gross anatomy standpoint, composed of only 4 different kinds of organs. These are the kidneys, ureters, urinary bladder, and urethra. One might summarize the physiology of the urinary system by stating that the kidneys form urine, the ureters transport it, the urinary bladder temporarily stores it, and the urethra excretes it. However, that would be an oversimplification because the process of urine formation has so many homeostatic implications. Urine rids the body of certain metabolic waste, especially urea, the end product of protein metabolism. Urine formation also allows the body to control its state of hydration, which influences blood pressure, and it helps the cardiovascular and respiratory systems control blood pH. Finally, by varying the loss of sodium and potassium in the urine produced, the kidneys help control the blood concentrations of these important electrolytes.
Hi, I'm Mike Shively. Welcome to Introduction to Anatomy and Physiology. In this session, our subject matter is the urinary system, but we kind of hurried through the respiratory system, and I want to give you students a chance to ask some questions, if you have any, on the respiratory system. Seth?
Yeah, I know that when divers are coming up to the surface, they have to control their ascent in order not to get the bends. What is the bends? How do you get it?
The bends is a situation where a diver has been at over a certain depth, and it doesn't have to be too deep. It depends on how much time they've spent down there, and actually has a certain amount of nitrogen that's been absorbed into the bloodstream as a result of breathing higher pressure air mix. And if they come up too rapidly, that nitrogen will tend to boil out of the bloodstream, causing small bubbles, which is where the bends come from. I think the name comes from the characteristic pose that you assume, all bent and folded up because of the pain when that happens. So by coming up relatively slowly, the amount of that passage of nitrogen is breathed off in the lungs rather than boiling out in the bloodstream. Another way that nitrogen can cause some problems too is if a diver stays down at a very high depth, they have to breathe such a high pressure mix that excessive amount of nitrogen will be forced into the bloodstream at those pressures, and they can suffer what's called nitrogen narcosis, which gives them a clinical condition that's not unlike being drunk with alcohol. Their judgment's impaired, and they start making crazy decisions like take off their mask and regulator and try to breathe water and that sort of thing. So that's what the bend's all about. And if an individual comes up too fast or is forced up for some other reason, they'll put them in a high pressure chamber, as quickly as possible and then allow that pressure to decrease slowly over time. I don't know if you are familiar with, I think they used to be called sand fleas or sand dogs or something, these folks that were involved with digging tunnels under rivers.
Sandhogs.
Sandhogs, is that what they're called? Those folks had to work under high pressure conditions, and they would have to spend some time in a decompression chamber, if you will, in order to allow that nitrogen to bleed off slowly, and so they could exhale it. What's going to happen? What are you going to do if you're in a restaurant or something, and you see one of your fellow diners over on the other side show signs of distress and start clutching at their throat like this? What are you going to do? You going to sit here and let them die?
What's wrong with you?
I can't talk.
Heimlich maneuver.
Could somebody demonstrate the Heimlich, the abdominal thrust maneuver on me? Oh. Okay, he's putting a fist in my abdomen, and he's going to squeeze really, really hard, forcing that fist into my abdomen. The idea being, I am in respiratory difficulty because my airway's blocked. I got a big old chunk of roast beef back there, and I got it jammed down into my larynx by accident as opposed down into my esophagus. And so what he is doing is he's taking whatever air that may be in my lungs, some air that may be clear down in my residual volume, He's forcing that out in an attempt to blow out the bolus of food that's blocking my airway. Don't be timid. If you're ever in a situation where you do this, break a rib. Really, really squeeze hard and fast, because that's really critical. If you get some of that, if you don't get the bolus out and get some of that air that's in your residual volume snuck past it, there may not be enough left in order to get the bolus of food out. Yeah, Adam?
I actually have two questions. When doing that, is there any danger of breaking off the xiphoid process?
Oh, probably, but that's the least of your worries. A broken xiphoid process can be dealt with. Death is hard to deal with.
And then my other question goes along with the diving question. I've heard that they've also used those hyperbaric chambers to treat carbon monoxide inhalation. What's the physiology behind that?
What they'll do, remember last time when we were talking about hemoglobin, we said hemoglobin has a much higher affinity for carbon monoxide than it does for oxygen. And so in a situation where someone is in difficulty because of in carbon monoxide poisoning, but they're not dead yet, they'll put them in a high-pressure chamber of pure oxygen or close to pure oxygen. And therefore, by having a real high-pressure chamber, you actually can, quote, force some of the carbon monoxide off some of the hemoglobin molecules and get the oxygen content of the blood up. So that's the theory. Susan?
I've also heard of anaphylactic shock reactions, and what does that do to the respiration?
You know, I've got some first-hand experience with anaphylactic shock. I've been there once, and my wife has been there twice. Mine was due to the fact that I received a tetanus antitoxin injection when I was a kid because I stepped on something, and they were using a lot of tetanus antitoxin then. And then several years later, I had an altercation with a coonhound, and they decided that perhaps I needed it because I had some puncture wounds as a result of his canine teeth in my leg. And so they decided to give me another injection of tetanus antitoxin. Of course, that stuff is made in horse serum. It's made in horse blood, really, in living horses. And so my body reacted to the horse protein, the horse serum. And I basically, in anaphylactic shock, there's some antigen-antibody reactions that cause bronchial constriction. And so basically you get where you can't breathe. And I was having respiratory difficulty. I had broken out into what by that time was one solid welt all over my body. And they got me in just as I passed out into a doctor who injected me with epinephrine, adrenaline, and hydrocortisone and that sort of thing. And within an hour, I was absolutely fine. My wife is one of those unfortunate individuals who is hypersensitive to bee stings. Of course, where we live, there's a lot of wasps, you know, so we keep lots of wasp spray around, you know, and it's my job to try to keep them down to a minimum around the house there. But Ann's been stung a couple of times with wasps to the point where she quit breathing, and it was only an injection of epinephrine again that caused bronchial dilation that saved her life. First time, I just happened to have some epinephrine, you know, because some of you know I'm a veterinarian, although I never practiced full-time. I happened to have some 1 to 1,000 adrenaline, and I was able to give that to her myself. The second time, I didn't have any. It was after we moved here. And my then 12-year-old son, I was trying to keep Ann kind of semi-awake in the back seat while our 12-year-old son took us down the canyon to the emergency center there at the little town, and that was quite a ride. I can remember, I don't know whether I was more scared for my wife or of course we were going to die from the auto accident. The urinary system. Now when we think of the urinary system, I want you to realize this is the simplest of the visceral body systems. Simplest in that it only has 4 major kinds of organs, as you saw in that pre-taped video segment. And those organs, of course, are 2 kidneys, 2 ureters, 1 urinary bladder, and 1 urethra. And as was mentioned there, the kidneys produce urine, the ureters transport it, the urinary bladder temporarily stores it, and the urethra is another transport tube, but it's for excretion. So let's take a look at a graphic that summarizes that. There's really not much to say beyond what we've said. Kidneys, ureters, urinary bladder, and urethra. Take a moment, students, and make sure that you separate these two words in your mind, because they both start out the same, and it's kind of awfully easy to get confused, and you mean one and you say the other, or vice versa. I don't think we have any problem with kidneys and urinary bladder, but ureters and urethra is quite often one or the other's confused for the intended meaning. Now, what does the urinary system do? Well, we can say, well, it manufactures, stores, transports, and excretes urine. But when we talk about the functions of the urinary system, we're really talking about the kinds of things that happen as the body forms urine. In other words, as these kidneys are manufacturing urine, what kinds of things do they accomplish for our body in that urine formation, in that process? What kinds of things? So think that way. Susan, what's one thing you'd think of?
Waste product, the urea.
We get rid of waste product called urea. I don't know if you know the chemical formula of urea. Let's go to the overhead for just a second. If I can remember what it is here. I think it's a carbon that's double bound to an oxygen that's got a couple of NH2 groups on it. Does this look like urea to y'all?
Yeah.
Yes.
Oh, good. Now, these NH2 groups are an end product of protein metabolism. As proteins are metabolized, when proteins go through the energy cycle, when amino acids, we break them down to amino acids and send those amino acids through the energy cycle enzymes do not accept compounds that have NH2 groups on them. And so what we have to do is we have to get those groups off, and by transamination and deamination reactions, we can remove the NH2 groups from those amino acids and then convert the carbon backbone of those amino acids into a hydrocarbon that can be incorporated into the energy cycle. At any rate, as those amino groups are taken off, the NH2 groups are taken off, they are combined with carbon to form this compound called urea. And urea itself, we've got to get rid of it out of our body, so it is an important function of the urinary system to get that urea into the urine that we're going to excrete. So basically it's simply, think of urea as a way of the body's way of dumping excess amino groups or NH2 groups. All right, it's a good one. What's another function of the urinary system? Adam?
Regulation of water.
Regulation of water. Let's suppose that I start drinking just a whole lot of water. Most of us don't drink enough. And matter of fact, some people have started filling up a bottle in so many times a day so they can keep track of their actual how much water they're taking in. If I start drinking a whole lot of fluid, what perhaps even excess from what my body really needs, what will happen? What will be the effect on the amount of urine that I produce?
It's going to
Increase.
It's going to increase. On the other hand, if I get really thirsty and I'm not taking in as much water as my body would really like for me to do, will that have any effect on the amount of urine that I produce in a given time period?
Yes.
Yes.
As a matter of fact, the urine output will reduce considerably, will it not?
Yeah.
So if we're dehydrated, the amount of urine that we form will be very scant, very small. The body's purpose in that is just a homeostatic mechanism, and it's perhaps abortive attempt to maintain as much water in the body as possible. On the other hand, if I'm taking in plenty of water or even more than I need, the urinary system will, in fact, dump the excess, and I'll need to urinate larger quantities and perhaps more frequently. So body water control is what Adam mentioned. Anybody else think of another function? Seth?
It controls the balance of electrolytes in the body.
Not only do we need to control the amount of water, but the ratio of the water to certain ions like sodium, potassium, and some other kinds of things is very critical. So if we have excess water, the body will hang on to sodium perhaps. If we have not nearly enough water in our body, if we're dehydrated, the body will tend to try to dump some of the excess sodium in order to keep the water-salt balance in the correct ratios. So not only do we control water content with the urinary system, but certain electrolyte levels as well. Can you think of another function, Eva?
It helps regulate pH.
Helps regulate pH. This is the third major body system that has a big influence on pH control or acid-base balance. We mentioned pH control with cardiovascular system. We mentioned it with the respiratory system and with the urinary system as well. The kidneys can, in fact, influence the level of hydrogen ions that are lost in the urine that's formed. So that's another important functional responsibility of the urinary system. You think of any others? Hazel?
It controls the blood pressure.
By controlling the water and electrolyte balance, that's one way that the urinary system controls blood pressure. And it does. It influences blood pressure dramatically by controlling water levels and electrolyte levels. It also influences blood pressure in another way because it produces a hormone, a substance called renin. And that renin is a powerful, indirectly, it's a powerful vasoconstrictor. And so by dumping out renin into the bloodstream, smooth muscle and certain blood vessel walls is actually influenced to contract. And if you contract smooth muscle and blood vessel walls, what's going to be the net effect on blood pressure? Go up or go down?
Go up.
Go and make the blood pressure go up, isn't it? Okay? Can you think of anything else? What about, I came from Texas, Indiana originally, then spent a bunch of time in Texas. Now down in Texas, we're about 200 feet above sea level. Where I live now, we're about 4,500, maybe 5,000 feet where I live, above sea level. Probably something happened to my red blood cell count between Texas. It might have been barely detectable, but I'm sure it was detectable. What would that be? Anybody? Susan?
The production of your erythropoietin, or the increase in red blood cells, because you need more oxygen at a higher elevation.
You bet. The kidneys produce another hormone called erythropoietin, and that erythropoietin actually targets bone marrow tissue and influences the bone marrow tissue to produce more red blood corpuscles. If you go from a higher oxygen level to a lower oxygen level, significant difference, then the kidneys will in fact release more erythropoietin, which will cause your red blood corpuscle count to go up. Sometimes endurance athletes, sometimes like marathon runners, training for Summer Olympics, they will go to a high altitude area to train. And why? Because they get a natural boost of erythropoietin, which increases their red blood corpuscle count, which increases their oxygen carrying capacity and enables them to compete more effectively. I remember many, many years ago, it would have been before your time, back in the 70s, and that is 1970s, y'all. But there was an individual I don't remember the name and I don't remember the exact year. It seems to me like it was 72, but there might not have been a Summer Olympics in 72. It was somewhere in the 70s. There was a marathon runner who did something that at that time was not illegal. It was called blood doping. Does anybody know what blood doping is? Eva?
Isn't that where you remove some of your own blood, just take it out, and then you wait a week or so while your body replaces those red blood cells, and then you inject your own blood back into your body so that you have extra red blood cells?
That's exactly it. Basically, they were increasing their own red blood corpuscle count by pulling out some of their own blood, allowing their body to replace that which was lost, and then later transfusing their own blood back in, and gave them a bit of an advantage again in endurance situations, endurance sports. Yeah.
When you change the altitude like that, how long does it take to change RBC count?
It takes a while, Bryce. In other words, you can't go run in a high altitude for a couple of days and expect to have much effect. But if you train over a period of weeks in the higher altitude and then compete in a lower altitude, you know, it's like a baseball batter getting up. You know, they'll put the little heavy ring on the bat and swing that around a few times. Then when they take that ring off, they theoretically can whip that bat quite fast. You know, swinging. We used to be swinging 2 bats because we didn't. When I was in Little League, we didn't have those fancy rings. You know, so you'd walk up there with 2 bats. You know, about as big as you were, swing those and then drop one and go up and face the pitcher. Let's take a look at a graphic that summarizes some of the functions of the urinary system. We've mentioned waste product elimination, especially urea. We mentioned hydroregulation, that's controlling of the content, body water content, and blood pressure regulation. We've mentioned acid-base balance. We've mentioned electrolyte balance. We've mentioned production of erythropoietin. I think we did a pretty good job. These are the major functions of the urinary system, and when you stop and think, these are all functions of the kidney, are they not? The kidneys are doing all of these things. The ureters don't do any of this, really, other than all the ureters, kidney, urinary bladder, and urethra do is transport and temporarily store. I do want to emphasize one thing, though, about kidneys, and that is they're producing urine all the time, 24/7. Now, the speed at which they are producing urine varies a bit, depending on our state of hydration and electrolyte balances and so forth. But I don't want you to think that when you urinate, that's when your kidneys are producing urine. No, your kidneys are producing urine all the time. The urine then is carried by the ureters down to the urinary bladder, which acts as an inflatable balloon, if you will, for storage of that urine. And then, when a suitable and socially acceptable time and place presents itself, you can unload that urinary bladder full of urine. All right. So much for overall parts of the system, components, and so much for functions. Let's talk about the kidneys for a while. Kidneys are intriguing organs. Let me bring a model of one up here. This one, we'll go to the overhead camera. This one has been sliced open and shows major anatomic features that we want to know. First of all, we can see the renal artery and renal vein, and this is the ureter right here coming in. And this is the medial side over here. Let me just write the word medial on this side. And if that's the medial side, then this other side must be the what? Lateral. The lateral side. So this is lateral over here. And the medial side of the kidney is actually called the medial border. So this side along here is the medial border of this kidney, and this side over here is the lateral border. I'm just going to go ahead and write lateral border. I'm not going to do it over here because I'd have to cross hands and I'd probably end up hurting myself again. Now, the top end of a kidney is the superior extremity, and the bottom end is the inferior extremity. So we got 2 sides, which are borders. We got 2 ends, if you will, which are extremities. And then we got a front side and a back side, anterior aspect and posterior aspect, which is, these are surfaces, okay? Anterior surface, posterior surface. So those are kind of the medial, lateral, front, back, top, and bottom of the kidney. Now this one has been modeled, this plastic model has been modeled as though we've got it sliced open and we can see inside. And it does demonstrate very nicely. The first thing that I want you to know about renal structure is it is divided into some outer tissue out here, which goes all the way around, of course. That's called the renal cortex. And then some deeper located tissue that's called renal medulla. Let me write those words down here so that you can see them. I'll just write renal, and then we got cortex and medulla. cortex comes from a word root which means bark, as in bark of a tree. So that kind of helps you remember that that's the outer part of the renal tissue. And then the medullary tissue is the more deeply located tissue. You'll notice on this model that the renal medulla is divided into chunks or segments. 7 to 9 chunks or segments. Each one of those segments of renal medulla is called a renal pyramid. So I'm going to write here divided into pyramids. The renal medulla is divided into pyramids. Now there's actually a capsule, a very thin capsule on the outside of the cortex. So, you know, if we're starting in from the outside, there's a thin capsule, but then the functional renal tissue is cortex and medulla. Now the urine that is produced by each segment of the kidney actually drains into an expanded funnel-like structure, and you can see several of them here. Here's one pointed up at the camera. Here's one kind of surrounding the tip of that particular renal pyramid, and one surrounding the tip of this one. Each one of these little collection devices, if you will, is a tubular channel called a minor renal calyx. And I'm going to just write the word calyx up here. This can be spelled C-A-L-I-X or C-A-L-Y-X. It can be spelled either way. So each one of these is a minor renal calyx. Now, you can tell in this model that several of these minor calyces actually coalesce to form larger collection channels. So although we have a minor calyx that's devoted to each renal medullary segment, these all coalesce to form typically 2 major renal calyces. And then finally there's a singular collecting area where it all comes together right here just inside the medial border. And ultimately, as that structure leaves the kidney, it becomes the ureter. So this particular part right in here is called the renal pelvis. So we got ureter, renal pelvis, major calyces, and then minor calyces. That's basically if we're starting on the trunk of this tree and then moving into the 2 big branches and the branches of their branches, if you follow. That probably wasn't a very good illustration, so I won't try it again. Okay? Mm-hmm. Minor calyx, major calyx, renal pelvis, ureter. So the 3 biggest things that you can see coming out along the medial border of this kidney, or in or out, are the renal artery, renal vein, and ureter. I've mentioned those already. There are 2 other structures that are located along this area and enter and leave the kidney right here as well. And those are nerves, which this model does not attempt to show, and lymphatic vessels, which this model does not attempt to show. Now, let me just put the same kidney up here in the form of a drawing, if you'll stay with me here for just a second. This indentation right here where stuff enters and leaves along the medial border, this whole thing is the medial border. But right along in here, this indentation is called the renal hilum. So we say the structures that we're talking about enter and leave the renal hilum. Now, when a surgeon does a kidney transplant, the structures that are most concerned during that transplant are those 3 big structures that the model did show. Renal artery has to be reconnected up, renal vein, and the ureter. I did a kidney transplant years ago on a dog. It was an experimental surgery exercise for us. And we left the other kidney intact, and you know, dogs like people can operate just fine on 1 kidney, so the dog was okay whether the surgery was a success or not. It took a team of 2 of us and we had actually 3 total involved in the project. It took us about 5 hours to do that surgery. Now, part of the reason that it took so long is because we were not experienced in vascular surgery. It's not just real easy to sew blood vessels together because you got to go all the way around, and it's really tiny and all that. But we were successful, and that kidney did in fact produce urine after it was an auto transplant. We basically took kidney out and reinserted it into the same dog. So it was, you know, we didn't have any trouble with rejection or have to worry about tissue types and that sort of thing. But tell you what, you do that, and it gives you tremendous respect for these specialist type surgeons that are involved in those kinds of procedures. And you all know that kidney transplants are relatively common and quite successful when they find an appropriate donor. It's kind of interesting. The donor themselves, their remaining kidney will undergo an amazing amount of hypertrophy after the first kidney, when they're donating, is removed. But that single kidney can adequately do the jobs of what 2 had been doing before. I was having some. Go ahead, Bryce. You had a question.
I was just wondering, when they find a donor and they remove the kidney, they tie off all of those main vessels and stuff that go in. Do those end up just sitting there, or do they kind of?
What happens when you obviously you have to clamp them off and tie them off, sew them shut, and with time those stubs undergo fibrosis, and it basically just seals off the end, and it's as though there hadn't been an opening there anymore. Does that make sense to you?
They're still full of blood. They just
well,
sit
usually
there,
with time, even since there's no blood flowing out of there, it tends to, the sealed area tends to regress back toward the, in this case, aorta, because these renal vessels are coming straight off the aorta, right?
Oh, okay.
So it goes. So you don't end up with a blood-filled stump. Of course, the renal arteries aren't very long anyway, but you don't end up with a blood-filled stump for years. It regresses and seals back, clear back toward the aorta. I was having some renal urinary system problems a few years ago, and they decided to do a excretory urogram. That's where they give you some radiopaque dye into your blood, which is excreted in the newly formed urine, and basically makes the kidneys, the ureters, urinary bladder radiographically visible. It makes it so that they become radio dense enough that you can film them with standard X-ray type equipment. And they positioned me for this thing and shot the film. And the technician, who happened to be one of my former students, in fact, came back and he said, "Have you had a kidney removed?" And I said, "Well, no, not to my knowledge." Of course, I would probably be aware of that, you know. And so he said, "Well, let's take another film." So he shot another film considerably lower, clear down in my pelvic region. And I have what is known in the business as a pelvic kidney. I have one kidney up here where it's supposed to be, you know, and I've got the other one clear down near the bottom end of my pelvis. And it had it was still functional. It was producing urine. Ureter was kinked back and so forth, but it still entered the urinary bladder. And I can remember when I was a kid suffering an extremely traumatic accident once when I was about in the 3rd grade. I fell off a tractor. A tractor wasn't moving at the time, but I fell onto the hitch mechanism and in my abdomen, you know, hit me in the abdomen and just essentially almost knocked me out. I was in severe pain for a long time, you know, laying there rolling around on the ground. And in talking to a urologist, he had suggested that perhaps what had happened, you know, is that my kidney, which, you know, normally up here plastered against the posterior abdominal wall, had become, due to the shock of that, had become knocked loose and had, quote, fallen, if you will, away from the posterior abdominal wall and was then ended up down in the pelvic cavity. So turns out that I was okay, and that kidney still seems to be functioning all right. So I just thought it was kind of interesting. Every once in a while we have somebody that's born with just a single kidney. Typically, in that case, the two kidneys will have fused together to make what's sometimes called a horseshoe kidney. So it's just one mass of renal tissue that actually has kind of grown together, if you will, but it's that way from a developmental outset. Let's take a look at a graphic here that summarizes some of the major anatomical features of a kidney. We've mentioned surfaces and extremities and borders and so forth. The hilum, we said, is located along the medial border. Again, that's the area where stuff enters and leaves. And the kinds of things we're talking about are the ureter and the various neurovascular structures that enter and leave at the hilum. And we've already said that the renal tissue is divided into an outer cortex and a deeper medulla, and that medulla is divided up into chunks or segments called pyramids. Do any of you have any questions about anything that we've said so far? Any renal questions? Bryce?
You said that when one kidney is removed that the other one grows to compensate. What does that do to your other body organs that are inside with the spaces?
Evidently there's tremendous ability. As you probably know, the abdominal organs, many of them, several of them, are quite mobile. Most notably small intestine, large intestine to a lesser degree, stomach and spleen can be shoved around. You ladies that have had children know that you can put a full-term fetus inside there, and things just get rearranged, and everything just kind of moves out of the way and gets shoved over this way or up that direction, so forth and so on. And same thing happens when a kidney undergoes hypertrophy, to a much lesser degree, of course. It's not nearly as severe to have a kidney that's half again as big as it used to be versus having a full-term fetus in there. So, any other questions, Adam?
What is the normal size of a kidney?
Let's see. A human kidney is about 3.5 to 4 inches tall. It's about an inch and a half to 2 inches thick, and it's about 2 inches or so wide. So, matter of fact, on this particular model, of course, I know perspective is missing, but this is just about a full-size model, a human full-size model. Very, very close. So, here's my hand. Don't have a dime, don't have a little centimeter rule here, Adam. And in their normal position, they are, positioned pretty close to the aorta, as you can see in this model. Here comes the aorta. Here's the inferior vena cava. Obviously, these are renal veins and renal arteries there. These structures here, you'll remember, sitting on top of each kidney. You remember what endocrine organ that was?
The suprarenal gland?
Suprarenal or adrenal gland, it's probably more commonly called. Of course, here comes the ureter streaming down here. Ureters have to come all the way down. If I get this model up where the camera can see it now. Ureters have to come all the way down to plug into the urinary bladder. And on this mucosal surface, you can see the openings of the left and right ureters on the mucosal surface of the urinary bladder. So I want you to think of the ureters as a transport tube that transport urine down from the kidneys as it's continually being formed at a relatively slow rate down into the urinary bladder. Now, as that urine comes into this urinary bladder is going to swell and get bigger and bigger and bigger, right? If you have a full-term fetus sitting on top of it, it's going to be crying out and saying, I need release. I need to empty here. Or if it's been a while since you visited that place, you may be talking to you a bit. Seth?
I was wondering, under what circumstances does a person need to go on dialysis, and how does that work?
Why would a person undergo dialysis, the process we call dialysis? Just for those of you who I'm not sure everybody's heard of it, but what's happening in dialysis is they're pulling some blood out of this patient, and they're sending it through a machine that will in fact allow some of the, quote, impurities in the blood, some of the urea and some of the other sorts of waste products to be removed, and then that plasma and that blood is returned back to that same individual. They do that, individuals undergo dialysis whenever their kidneys are not functioning properly, whenever they're going into renal failure. And it's very expensive, and it can become very time consuming. Now, depending on how at what stage of failure your kidneys are in, a given individual may need only a few hours of dialysis each week, or maybe a lot of hours of dialysis each week. And when you get into those kind of situations, those individuals are waiting, in all likelihood, for kidney transplant. Basically what's happening in those instances, Seth, is the kidneys are shutting down and are unable to perform their normal physiologic function. And so we've got artificial machines that are doing it for them. But it does take time in order to get that process done. So you can't just go in, oh, 5 minutes, I'm done and out of here. No, you'll be on there for a lot of hours, in fact. Let's talk about the ureters a little bit more. Let's take a look at a graphic here. We've got an abdominal and a pelvic portion of that ureter. That's just a dividing line between what we call abdomen and pelvis. There are actually 3 layers in the wall. On the outside, we've got some peritoneum making up what we call the serosa or serous membrane. In the wall of the ureter, forming most of the wall, is what we call tunica muscularis, or often just shortened as we have it here to muscularis. And finally, lining the ureter is a mucous membrane. Now, this muscularis is very important because it's peristaltic waves or contractions of that smooth muscle tissue which move urine from the kidneys down into the urinary bladder. I don't want you to think this is a gravity feed thing, you know, where, well, kidneys are above, you know, the urinary bladder, so obviously it's just gravity that pulls that urine down the ureters. These are not like soda straws. There's actually peristaltic waves of contraction that occur in the wall due to that smooth muscle tissue, which forcibly moves the droplets of newly formed urine from the kidney down into the urinary bladder. Now, when the ureter comes into the urinary bladder, let's go to the overhead camera for just a second. Let's say this is a urinary bladder, and we'll give the wall some thickness. I'll need thick wall here for purpose of illustration. When the ureter actually comes in, it doesn't come straight through the wall like I'm drawing it here. This is the no way to do a ureter into a urinary bladder. And we'll draw a little circle there to represent the opening. If it were arranged like this, with just kind of a straight shot through the bladder wall, as the pressure increased in here because collection of more and more urine, the back pressure would be directly into that opening, and we get the ureter pressurized up all the way up to the kidney, and we can end up with a condition that medical practitioners call hydronephrosis. Simply a reflux of urine from the urinary bladder directly up the ureter. In order to combat that, when ureters come in, they actually curl down around here and slant relatively obliquely through the wall. Let me open up that lumen a bit. Now, as the urine collects in this urinary bladder and pressure is put against the wall, it tends to kind of kink off the end of this ureter by simply, you know, you got a hose and you can step on it with your foot and kind of stop a lot of the water from coming on through. You got one of the soft-sided hoses like we've got at home. You can. Really high-quality hose. You can step on it, nothing happens. But what happens here is the pressure of the urine in the urinary bladder will mash against the wall of this urinary bladder and actually cut off the opening of the ureter. Go back to the overhead for just a second. Now, the peristaltic waves, the contractile waves of the muscularis, are sufficient to drive droplets of urine by this pressure, and so urine can still enter the urinary bladder. But the pressure is enough here to prevent the back pressure from flushing urine back up. Does that make sense to you? Now, I had a granddaughter that was born a few years ago, and her ureters were a little bit more like this situation over here. They came through the urinary bladder wall at kind of a perpendicular or too straight an angle. And she was having some urinary system problems. What the surgeon did was go in and detached both ureters and reinserted those ureters through the bladder wall, more like what they're supposed to be, more at a more oblique angle, like over here. And she's gotten along fine since they did that surgery. The situation where urine is backing up into a ureter is called vesicoureteral reflux. If we can go back to that previous graphic, the one that was up there just a second ago, I didn't say anything about that. Here we go. That last point on that graphic right here, the oblique passage of the ureter through the bladder wall is what is considered to prevent or be a major factor in preventing vesicoureteral reflux. This part of the name vesico is just a medical term for the urinary bladder, and obviously you can see ureter in that part of the name. Bladder to ureter reflux, to prevent urine from passing from the bladder back into the ureter. Any questions about that? Adam?
What causes a kidney stone?
Oh, we're coming to that. Hang on to that just a
Okay.
second. Let's talk about urinary bladder, and we'll talk about all kinds of urinary calculi here in just a moment. Urinary bladder, let me pull the model back up here, has an apex, fundus, body, and neck. I don't think those parts are all that important for us to memorize in this course. But think of it as a little balloon. When it is empty of urine, like it is right after we urinate, it's very, very small. And then it can get, along about 4:30 or 5 o'clock in the morning, it can get pretty large, can it not? There's actually two sphincter muscles. I want to go to the, stay on that overhead for just a minute. I want to put a urinary bladder up here again. There's actually two sphincter muscles down here. A internal sphincter and external sphincter, they're sometimes called. This one is made of smooth muscle tissue. I'm going to put MT for muscle tissue. And this external one is made of skeletal muscle tissue. And both of these sphincters have to be relaxed in order to allow urine to pass from the urinary bladder out into the urethra. Okay? And it's smooth muscle contraction of this within the urinary bladder wall, which actually forces that urine out. But these two sphincters both have to relax. When you really need to urinate badly, you're on the interstate and there's been an accident up in front and you had to go before you got in the car even, and for some reason it's taken them a while to clear the highway. This smooth muscle sphincter finally gives up the ghost and says, you're on your own. And so the only thing that you've got holding the urine back in this urinary bladder is continual contraction of this skeletal muscle sphincter. And you have to keep sending messages down saying, hang in there. Keep contracting. Why? Because skeletal muscle tissue has to have impulse in order to contract. And if you don't find a place pretty soon, once you get to this stage, once this smooth muscle sphincter gives up and you get to this stage right here, it's not going to be very long until you lose it. And you just hope that nobody tells a really good joke about now, because it'll be pretty tough. All right, let's take a look at a graphic that summarizes those things. Apex, fundus, body, and neck, those parts aren't important for us, I don't think. The trigone, I didn't mention that, but let's go to this model and I can show it to you very quickly. The trigone is simply a landmark on the mucosal surface of the bladder. It's a virtual landmark connecting the opening of this ureter, the opening of this ureter, and the opening down here of the urethra. So that makes a triangular shaped landmark that's called the trigone of the urinary bladder. Simply a a connection between the two ureteral openings and the urethral opening. And then I've already mentioned that we've got two different sphincter muscles that must relax to allow the urinary bladder to empty. Adam?
So what happens when you're using the restroom and one of your good friends decides to bang on the door as loud as they can and all of a sudden everything stops?
Yeah. When you get in a situation where you really need to urinate but are having trouble, or the phone rings or something like that, somebody beats on the bathroom door, what happens is particularly that smooth muscle sphincter goes back into a spasm and clamps down on you. And so we call that psychic anuria when that happens. And that's a real term, incidentally. But it's autonomic nervous system control over the smooth muscle sphincter that'll go in there and cause that guy to clamp down. Then it may take a little bit for that fellow to relax on you again. Okay, the one part of the urinary system that we haven't talked about yet is the urethra. We're actually not going to talk about it much today because I want to save that for when we're talking about the male reproductive system and female reproductive system, when we'll have other parts here. You take a look here on this model. If we can go to the overhead camera, you can see that we're cut off a little bit short right here, because here's the urethra starting, and this is obviously a male because we got a prostate right here, and then that urethra will go down through the length of the penis. So it's going to be several centimeters long in a male. It's going to be considerably shorter in a female. Matter of fact, in a female, it's only 2 or 3 centimeters long, and that's one of the reasons why ascending infections of the urinary bladder are much more common in females than they are in males. If we look at this graphic that summarizes some facts about the urethra, we say it's 18 to 20 centimeters long in males, and it's divided into a part within the prostate. It passes right through the middle of the prostate, called the prostatic part. Then there's a part where it goes through the inferior abdominal wall, called the membranous part. And then the portion of the urethra in males, which is in the penis, is called the spongy portion of the urethra. So males have these 3 distinct parts. In females, we usually don't make that distinction. It's only 2 or 3 centimeters long. Now, Adam, you asked about urinary calculi. These are concretions which form in the urinary system and can actually be found in any part of the urinary system. We can have them in the kidneys, we can have them within the ureters, we can have them in the urinary bladder, we can have them in the urethra. If we have them in the kidney, we call them renal calculi, or renal stones, kidney stones, if you will. If they're in the ureters, we call them ureteral calculi. In the urinary bladder, they're called vesicular calculi or cystic calculi. And then if they're in the urethra, we call them urethral calculi. They basically form as precipitations, and they can be formed of a lot of different kinds of minerals. Let's take a look at a graphic that summarizes some facts about urinary calculi. They can be formed of phosphates or oxalates, and usually those are radiographically visible. In other words, if they're made out of what we call phosphates or oxalate type materials, that's the principal minerals in them, then we usually see those radiographically on a standard film. They can also be formed, however, of urate crystals or cysteine, and those usually cannot be picked up radiographically. And again, they're classified, depending on where they are, as renal, ureteral, cystic, or urethral. I have not had the experience, I don't believe, of ever passing a ureteral calculus, but when one of these stones moves down a ureter and starts stretching, and perhaps because it's sharp-edged or kind of rough, like a sharp rock in your shoe, starts ripping on the inside of the wall of that ureter, that pain is supposed to be really quite excruciating. Matter of fact, I've had some students, female students, that said, I've given birth to several children, and I've had the ureteral calculus moving down, and I'd rather give birth than to have a ureteral stone move down. Incontinence in the urinary system. Urinary incontinence is basically a situation where you cannot urinate when/where you want. In other words, you kind of lose control of the urinary system a bit in regard to urination. Let's take a look at a graphic that summarizes the different kinds of urinary incontinence. We've got what we call neurogenic, non-neurogenic, and paradoxical. Let me see if I can differentiate some ideas of what we're talking about just with these three. By neurogenic, we mean there's a problem with the nervous system control of the smooth muscle contraction of the urinary bladder or the movement, you know, down through the urethra. Non-neurogenic typically is a conformational defect, and I'll talk about one of those in a second. Paradoxical incontinence, classic form of that is when we do have a calculus that's blocking the channel. So we can understand this one real easy. We can understand this one. Nerve supply problem, and we got a blockage. What about this one? Well, remember when we drew the urinary bladder, let's go up here to the overhead for just a second. When we drew this urinary bladder, we said the ureters come down from the kidneys and plug through the wall like that. Well, what about if this ureter, for some reason, instead of going into the urinary bladder, actually comes down and plugs into the urethra itself? Does this kidney still produce urine up here? Yeah. Does that urine still come down here? Yeah. But it's not stored in the urinary bladder, is it? It'll actually go right on down the urethra, and this person will be a dribbler. Okay, this person has a nerve supply problem. This person may have a conformational defect. This person has a blockage. Only one of these three can urinate normally. That would be the non-neurogenic with the conformational. If they had an ectopic ureter, for example, they would be able to urinate normally involving the other side. Distended urinary bladders are going to occur up here because the nerve supply is not there to cause the smooth muscle to contract, and down here because there's a physical blockage. These two can be easily catheterized, but this one, because of the physical blockage, cannot. Okay? We'll continue our discussion of the urinary system next time.